talk entitled NKG2C positive, NKG2A negative, CD56 dim subset of NK cells show increased anti-leukemia potential in the presence of CTLA-4 in vitro, and is the key determinant of early relapse and long-term disease-free survival without GVHD following CTLA-4 IgDLI-based haploidentical HCT. We'll have to ask TCT to reduce the number of words for the titles, because every talk has 3 lines of titles. Please.
Definitely. Thank you, Chairperson, for the kind introduction. Today I shall be talking about the extension of our previous study, which we had presented in the same forum 24 months back, about our novel approach to immunotherapy in the patient with advanced leukemia undergoing haploidentical transplantation, which we had later presented to BMT. And what we had shown at that time was the incidence of NRM was pretty low, with the acute and chronic GVHD also low, and the overall incidence or overall survival was 80%. So at that time, we had postulated that it could be due to early and sustained recovery of mature NK cells and early and sustained recovery of mature NK cells. So coming to the NK cells, which has got, we all are aware that bunch of activating and the inhibitory receptors. Now I am going to focus only on the lactine group of receptor, that is the NKG2A and 2C. So it's the corresponding receptor for the NKG2A is HLA-E ligand, which is ubiquitously present in the human all mammalian cells. And that's how there is inhibition of autoreactivity from the NK cells, because this HLA-E ligand is present on all the mammalian cells. Now coming to NKG2C cell, which is not activated, which does not appear of alone, it requires certain kind of stimulation, and possibly CMV exposure is one of them that leads to NKG2C appearance, and NKG2C appearance leads to strong anti-leukemic effect, and that is how we are trying to study in this study about NKG2C receptors association. So in a larger cohort of patients, of 60 patients, we had tried to find out the impact of NKG2C cells on disease progression, NRM, overall survival. Not only the phenotype, we have also studied the functional assay of NKG2C on the disease progression. And as we were using the CTLA-4 Ig, that is a beta sept, and the good thing is that it is now approved in the context of bone marrow transplantation, which we are using for the last 5 years. And what is its correlation in terms of NKG2C? Whether this is doing something better and a bigger way in terms of dissecting GVL effect or GVHD. So this is the table showing the 60 patients, the donor and patient's characteristic. So the median age of patients was 20 years and the donor age was 33 years. We had looked into the donors' KIR haplotype, and most of our patients has received from KIR-B haplotype donor, that is 80%. The median value of CD34, CD3 and NK cells in the graft were 8.2 million, 16.8 and 2.3 millions per kilogram. And fortunately, all of our patients and the donor were CMV seropositive. This is our protocol, which consisted of flu-bu meal protocol, which we had already published. And we have used PTCY along with short course of cyclosporine A. In addition to this, we had added abatacept at a dose of 10 milligram per kilogram per dose on day -1, +6, and day +21, and day 35. And after 24 hours of this, we had used donor lymphocyte infusion at a dose of 1 to 5 million cells per kilogram. The engraftment was not a problem with acute neutrophil engraftment was 15 days and the platelets were 14 days. The incidence of acute and chronic GVHD were 12.2% and 19.8% respectively. The incidence of non-relapse mortality was similar as compared to our previous protocol, that is a 5%, and that possibly has translated to the overall survival of 86.5%. The disease progression was 17.6% in the whole of cohort. So we had tried to look into the risk factors which are associated with disease progression, and what we found that the patient who had myeloid leukemia and who had received from KIR-B haplotype donor had a very low incidence of disease progression, that is 7% and 10%. So in continuation to our initial protocol, we have studied all type of immune reconstitution at a various time period, day 30, day 60, and day 90. And along with that, we had also studied at days 180, 1 year, 2 years, and 3 years. And what we found that it is the mature NK cell which reconstituted early in a patient who did not relapse. And this is the NKG2C population, which where median values are here. Now the question was that whether NKG2C reconstitution was influenced by CMV reactivation. Yes. On the day 30, patient who did not acquire NKG2C cells had a CMV reactivation more. But, however, on the later study period, there was no statistically significance with the CMV reactivation. Now, this is the key point of our study was NKG2C reconstitution. What is the correlation between NKG2C and the relapse? What we seen that the patient who did not mount NKG2C receptor had a higher incidence of disease relapse, even who had received cells from a CMV seropositive donor. And not only that, even later time period, patient who had survived, their NKG2C population remained increased. Now coming to the functional assays, what we have studied the interferon gamma release in the aspects of NKG2C, and here you can see the patient who did not relapse has a higher percentage of interferon gamma release on day 30 and day 60. This is the scatter plot which is showing the statistically significant improvement in the interferon gamma expression on NKG2C cell as compared to the patient who did relapse. This is the overlay histogram where you can see we had did the study, in vitro study, where we have used CTLA-4 Ig, and what you see the expression of interferon gamma in the in patient who did not receive in the study where CTLA-4 was not used in the green, and the red one where CTLA-4 was used. Now the other point of our study was what is the relation with NKG2C with the GVHD. So what we found that the patient who did not had higher percentage of NKG2C on day 60, they had a acute GVHD, and at the same time, NKG2C cells at the day 180 was higher in patients who did not develop chronic GVHD. So apart from anti-leukemic property of NKG2C, it had also property that it deactivate the host dendritic cells, and also it inhibit activated T cells that possibly led to decrease in the incidence of graft versus host disease. Now, intuitively, it is believed that T regulatory cells inhibit it causes the relapse. But what is in our cohort of patient who did not relapse has a higher percentage of T regulatory cells. Now, what is the reason for that? In conventional NK cells, in presence of T regulatory cell, it reduces its cytotoxicity, but in the lower panel you can see in presence of these adoptive NK cells, they have a higher cytotoxicity. So, in conclusion, we can say that in a larger cohort of patients of acute advanced leukemia, with a longer follow-up, CTLA-4 prime donor lymphocyte infusion has been shown to have an excellent anti-leukemic effect with lower incidence of graft versus host disease as well as NRM. This salutary effect of the approach was predominantly seen with the patient who had a myeloid leukemia and also who had received a graft from B haplotype donors. So that this long-term anti-leukemic effect of NKG cells was mediated by the NKG2C subsets, as it is evident by their early surge and long-term persistence in those with disease-free survival. This effect was independent of CMV reactivation in the patients. Not only the phenotype, the functional assays revealed that the greater interferon gamma release in this subset in those patients who did not relapse. And most notably, interferon gamma released by NKG2C subset was markedly enhanced in presence of CTLA-4 in vitro, and possibly this validates the concept of CTLA-4 IgD-LI as a unique approach to enhance anti-leukemic property of NK cells. This NKG2C was also associated with attenuation of both acute and chronic GVHD. The sustained reconstitution of TREX post-transplantation along with NKG2C had a synergist effect on NKG2C subset with T regulatory cell in providing which had low incidence of graft versus host disease. And possibly this provides an excellent model to study the clinical possibility of dissociating GVL and the GVHD. So I thank you all. This is my team, and this is my mentor, Dr. Chakravarti, who is the pioneer of this innovative approach. Thank you all.
Thank you.